Hello, welcome everybody. I see folks are popping into the webinar. I'll give people a few more seconds here before we start in earnest. Get everybody who is in the waiting room in a timely manner in here. I know we'll have people coming in for the first few minutes. All right, I think that empties our waiting room. Thanks for being prompt, everyone. My name is Matt Shepard. I'll be moderating today's session on the federal nursing home reform law and lessons it holds for today. Our presenters today are going to be Center for Medicare Advocacy Senior Attorney Toby Edelman, the National Committee to Preserve Social Security and Medicare Senior Expert on Healthcare Policy, Ann Montgomery, and Lori Smetanka, Executive Director at the National Consumer Voice. Before we hear more about these organizations, bear with me for a little housekeeping. As with all online presentations nowadays, we know our audio and video are at the whim of the internet, so definitely be aware, especially in this season of weird weather. Also make sure that you have the correct microphone and speakers set in the audio controls that should be down at the bottom left of your viewing screen. And should you have any trouble watching, listening, speaking, whatever it might be, all registrants will receive a link to the recorded presentation in a follow-up email that you'll get from me. When watching today, note that if you don't want to see empty boxes of presenters who aren't live on video, you can change that in the view menu. Just say hide non-video. We have a lot of content today. Not sure how much time we will have for discussion, but on that topic, please note that Zoom has, in addition to the regular chat window, a questions button. You can type questions in there as you have them, and I'll monitor those as we go along, and I can pass them on, time permitting. Speaking of that regular chat, you'll note I've put a link in there to today's slides in case you didn't get that earlier today. And when you check that chat, please feel free, say hello, let us know what state you're from, let us know what organization you're with, anything else you want us to know about you. Almost there. Now a little bit about the center, who's hosting today. Center for Medicare Advocacy is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities by providing exceptional legal analysis, education, and advocacy, all based on the experiences of the real people who contact the center every day. Now, with that out of the way, let's welcome Center for Medicare Advocacy Senior Policy Attorney Toby Edelman to get us started. Toby.
Thank you, Matt. I want to thank Lori and Ann, who are longtime colleagues and wonderful advocates, and I think they have a lot to contribute to us today. In the days immediately following the election this past November, I drafted the PowerPoint that we'll be using today. Instead of feeling despair, I wanted to tell how we got from deregulation in 1981 to the Comprehensive Nursing Home Reform Law in December 1987, all under the Reagan Administration. It's quite a story. So next slide, please, Matt. That is the purpose of this, to say how we got to the reform law and how we can do this again. How did we get from deregulation to the most comprehensive nursing home bill in U.S. history? Next slide, please. We need to go back a little bit to the Carter administration. In 1978, the administration held a series of public meetings under the title New Directions for Skilled Nursing and Intermediate Care Facilities. Skilled nursing, the Medicare term; intermediate care facilities, the Medicaid term. The purpose was to simplify regulations, making sure we were focused on residents, controlling costs, and getting better compliance. There were public hearings and a number of questions that were posed for public comment. Next slide, please. In July 1980, the Carter administration proposed a rule. They responded to the public hearings, and they wanted to revise the conditions of participation, was what the standards of care were called at that point, to identify 12 issues. One point was to combine the requirements for facilities for Medicare and Medicaid instead of having separate rules for each, strengthen the role of medical director, and elevate the residents' rights to a condition of participation. Only conditions of participation were enforceable. Standards, which is what residents' rights were not really legally enforceable. Unfortunately, in December 1980, after the election, Congress passed a law which said that the HCFA, at that point, the Healthcare Financing Administration, could not publish anything in the Federal Register related to the proposed rule unless the GAO had evaluated the impact of the regulations, and certainly not before January 12th, 1981. Next slide, please. That did not happen. The GAO did not do its analysis, but nevertheless, HHS Secretary Patricia Roberts Harris tried to implement one part of the proposed rule. The one thing she tried to sign was elevating residents' rights from a standard to a condition of participation. Next slide, please. On January 21st, 1981, literally the first action at HHS was withdrawing secretarial approval of residents' rights. And then in January 23rd, a couple of days later, they published a notice in the Federal Register explaining why they were doing what they were doing, that it was a result of the law that Congress had passed. Next slide, please. So then the Reagan administration was there in earnest, and it began to implement what its view of nursing home rules would be. And things went downhill from January 21st. Next slide, please. In early 1982, the National Citizens Coalition for Nursing Home Reform, NCNR, now called Consumer Voice, headed by Lori Smetanka, I believe NCNR received in the mail in a no address saying where it came from, but it was regulatory requirements that somehow omitted residents' rights. Just no rights at all for residents, on the theory from the industry, the nursing home industry, that there was no statutory authority for residents' rights. That became public pretty quickly, and immediately the HHS Secretary Schweiker issued a press release in March saying, we are not going to turn back the clock on residents. Don't worry about it. It's not going to happen. We're not going to change health and safety requirements. They'll stay the same, untouched. Next slide, please. So the administration was stymied in turning back the clock on the legal requirements that nursing homes have to meet to be eligible for Medicare and Medicaid reimbursement. But what it did instead, or as an alternative, was to change the survey and certification rules. And as the Institute of Medicine said later, that the administration found it impossible to change the standards. And so instead they said, we will change the survey and certification requirements. Next slide, please. May 1982, they were true to their word, and they proposed changes to the survey and certification rules. These were called Subpart S regulations. They called for less than annual surveys, nursing homes to say in the self-survey how they were doing. And the most controversial part, I believe, was deemed status for facilities that had accreditation, the Joint Commission on the Accreditation of Healthcare Organizations. At the time, the Joint Commission not only scheduled surveys, not only were they not unannounced, they were scheduled. The facilities were told what day they were coming in, and the survey results were kept confidential. At one point, I saw an example for hospital staff saying, here is what the Joint Commission will ask you, because they knew when Joint Commission was coming in for hospital accreditation, and here are the answers you will give. So many of us were quite concerned about these proposed Subpart S regulations. Next slide, please. Residents advocates responded very, very quickly, with NCNR leading the way. And one of the important things people did was show that facilities that were accredited were actually being decertified by their state agency, to make the point that actually accreditation did not mean high quality care. And that was a very serious concern. We even had demonstrations that year with signs saying no Subpart S. It was quite a crazy time. It's hard to imagine people walking around having signs saying no Subpart S, but that is what we had. Next slide, please. Just weeks later, literally weeks later, in July 1982, the Senate Special Committee on Aging held a hearing called Nursing Home Survey and Certification, Assuring Quality Care. At this point, the Republicans controlled the Senate. John Hines was the chairman, Republican from Pennsylvania, and he said, quote, "I've given these proposals very careful consideration, and regrettably, I have concluded that they will seriously reduce federal and state oversight capabilities. I believe they will strip the nursing home inspection program of its ability to monitor and enforce the established basis standards of nursing home care." Next slide, please. And he said, to relax enforcement renders existing standards meaningless. Next slide, please. We had another Republican senator on that committee, Senator Percy from Illinois, who said he had served on the subcommittee on long-term care and investigated nursing homes. It was something that was of importance to him in particular. Oh, excuse me, I'm just having a problem with my computer. Okay. And he said he was very concerned about the deemed status proposal as well. Next slide, please. Bipartisan congressional opposition mobilized very, very quickly. And by June, just a couple of months later, 35 Democrats and 11 Republicans in the House opposed the rule, came out publicly opposing Subpart S. All 15 members of the Senate Aging Committee, Democrats and Republicans alike, urged the administration to withdraw the Subpart S regulations. Very serious concern. And the chairs of the 4 House committees with jurisdiction over healthcare all introduced legislation to impose a moratorium on any type of deregulation of nursing homes. Next slide, please. Congress followed through on the moratorium, and in fact, 2 legislative moratoria were enacted. The first was in the Tax Equity and Fiscal Responsibility Act of 1982, September 3rd, and the second moratorium in the budget resolution later in 1982. There was about to be a third legislative moratorium when Congress reached an agreement with the Healthcare Financing Administration to fund a study by the Institute of Medicine at the National Academy of Sciences, and no deregulation would be permitted while the IOM conducted its study. Now, we, of course, had never heard of the IOM or the National Academy of Sciences, but we were pretty delighted because we knew that this would take time, a study would take some time, and at least there could not be any change in the nursing home standards while that study was underway. Next slide, please. So while we were waiting for the IOM committee report, and that took several years, next slide, please, people kept working anyway. And one of the interesting and important reports that was issued was by NICNR. It was the Consumer Perspectives on Quality Care, the Resident's Point of View, which my understanding was the first time that anybody had ever asked residents what they wanted. Not for NICNR wasn't the first time, but for other people, it was the first time they had heard that residents were asked what they actually wanted. And Lori's going to talk a little bit about what that report said. Thanks, Lori.
Thanks, Toby. Thanks so much for inviting me to be here, and so appreciate the partnerships that I've had with you and with Anne over the years, and I'm really glad to be able to talk about the work that historically we have done at the organization as we're celebrating our 50th anniversary of advocating with and on behalf of residents of long-term care facilities. So as Toby said, while they were waiting for the Institute of Medicine study to be conducted, NICNR, Consumer Voice at the time, did its own study of asking residents what they thought quality care, what determined quality care for them and how it could be measured. And so this was really the first time it had ever been done. It was done in a series of small focus groups over 15 cities where 450 nursing home residents participated in these focus groups. And residents were asked about quality care and what that looked like for them. And what was really interesting about it is that I don't think any of us will be surprised about the range of topics that were raised by residents during that time. So the residents focused on things like staffing, having sufficient numbers, positive staff attitudes, good staff relationships with residents, the importance of qualified and well-trained staff. They talked about better pay and career development possibilities for people that worked in nursing homes, and ways to improve the quality of staff by better supervision, orientation, and training. They talked about the importance of activities in their daily lives and how they wanted a variety of activities, and they wanted to be able to have choice in when they participated in them, and what activities were being offered. And they also wanted to be part of community activities, not just things in the nursing home. The residents talked about food and food service, about how important that was to not only their care, but their quality of life, and how they wanted the food to be fresh and well prepared, and tasty, and provide for ethnic differences, and served on time, and be hot and have seasoning, not just bland food that they are receiving cold. They wanted input on a lot of the things that they talked about, including food and including activities in the facility. They talked about choices and how they wanted to have choice in their lives about when they got up and went to bed, and to come and go as they pleased within the nursing home and outside of the nursing home, and as well as in the activities that they participated in, and also in their daily schedules and in their roommate assignments. A lot of the things that we see in residents' rights today are things that the residents had talked about there. And they also wanted channels for solving problems, which included a resident council working through the facility and working with the long-term care ombudsman program. So it was really critical that be part of it. The 15 focus groups, the results of those focus groups were then brought together, where there was a national symposium where residents and staff and other professionals came together to talk about all of the findings from the 15 focus groups that were held across the country. And they came together to talk about what types of recommendations they could make, and look to move forward with the findings that they had and what the residents had talked about. And it was, again, one of the first times that residents were actually at the table with the broader range of stakeholders who were providing care, who were advocating for care, who were regulating this care and services in long-term care facilities, who not only were the staff, but also the owners and operators of facilities, and residents were right there at the table. And some of the main conclusions that they found through the symposium, and that were really the findings of this report, included that the residents emphasized the need for resident participation in decisions about their care and their treatment, in decisions about the operation of the home, in policy development and in evaluating care. It was really critical that there be a lot of focus on residents' rights, and that be incorporated into all aspects of residents' lives, as well as operations of the facility, and that residents really needed to be engaged at all different levels. And the third area that they really focused on, again, was staffing, in terms of having adequate numbers of staff and adequate staff training. So that really fed into the work that was going to be looked at once the Institute of Medicine study came out again. And as I mentioned, you will recognize all of these things in the nursing home reform law that ultimately ended up passing. And so Toby, I'll turn it back to you to kind of talk about where they went after the report came back in.
We should have just listened to the residents right there. They had it all. Everything
Absolutely
right there. It's a really good point. Next slide, please. Something else that happened that was pretty amazing was the actor Kirk Douglas. Now, I don't know how many people now know Kirk Douglas, but he was incredibly popular, maybe in the 50s and 60s, maybe even in the 40s. He was very famous. When he died, my husband and I watched Spartacus, which is one of his most famous movies. It's really great. He's the He-Man, and people loved him. He was in a television movie called Amos about a nursing home resident. And he wrote an op-ed piece, or an op-ed piece with his name was published in the New York Times in 1985. And he said that he had seen the script and it didn't make sense to him. It just seemed so terrible. And he thought it was exaggerated, but then he found out it was true. And so his op-ed piece was "The Abuse of the Aged Must End." Next slide, please. So there was a hearing with Kirk Douglas testifying. This was a hearing of the Senate House Select Committee on Aging. We used to have a House Aging Committee. We haven't had one in years, but it was a very important way of getting information out. And the entire committee was up there. Everybody was up there falling all over themselves about Kirk Douglas, because they, of course, all knew who he was and they admired him. And people were saying things, I'm so proud to be an American because you're here. And they said, Mr. Douglas, tell us, what do we do to improve nursing homes? And his response was, look, I'm an actor. I'm here to bring attention to this issue. And this is a time when every hearing had a movie star. If there was a problem about family farms, you had a movie star who was in a family farm movie, and that's who testified. So here's Mr. Douglas saying, I'm here to bring attention to the issue. But if you want to know what to do about these problems in nursing homes, you listen to the experts who will testify after me. And Elma Holder was one of the, from the head of NICNR, the founder of NICNR was testifying. I was sitting with her and with my colleague, Trishni Moore. And after Mr. Douglas left, almost the entire committee, except for the chairman, Claude Pepper, left. And he kept the hearing going. And they were, of course, last witnesses changing their testimony, but it did get attention. It was very important getting attention because people really love Kirk Douglas. He came with his son, Michael Douglas. Maybe people are more familiar with him. Okay, next slide, please. So then we have the Institute of Medicine report. Now, IOM had convened, this is federally funded study, convened a panel of leading research experts in the nursing home field. Charlene Harrington, whom I think many people will know as an expert in nurse staffing, still going strong today in supposed retirement. Catherine Hawes, Bruce Vladeck, who later became administrator of the Healthcare Financing Administration and the Clinton administration. We got one brilliant resident advocate on, Iris Freeman of Minnesota. And what IOM did over the course of 2-3 years was review all the literature, all the reports on nursing homes. It conducted independent research. It invited outsiders like me to a handful of the meetings. But mostly it just worked by itself quietly, and that meant nothing else could happen. It released its report in March 1986 and recommended changes to the entire regulatory structure for nursing homes. The standards that facilities have to meet, the survey process to determine compliance, and the enforcement system. Next slide, please. And its tone was very measured, and it became what everybody acknowledges is the blueprint for the nursing home reform law that was enacted in 1987. It made very detailed and specific recommendations on the standards of care, survey, and enforcement. It said we cannot use a market-based approach to improve quality. We've done that, and it doesn't work. And they said there were two important goals: consumer protection and making sure public funding was spent properly. Next slide, please. So the staff of the IOM committee were very proud of their report with good reason. And they challenged NICNR, challenged Elma directly not to let that report sit on a shelf the way so many reports have in the past. Good reports, nothing happens with them. They said, do something. You have to do something. And NICNR convened what it called the Campaign for Quality Care, inviting anybody who was interested to review the IOM report. Everybody would read it together and then develop recommendations about how to implement the specific recommendations of IOM. Did we agree with them or not? And we met weekly for about a year, focusing on the standards of care that nursing homes would have to meet. So Laura, you might want to say something about the Campaign for Quality Care.
Yeah, absolutely. And if you could move forward to the next slide, you'll see a picture of Barbara Frank, who was the associate director of NICNR at the time. She and Elma worked very closely on the development of all of the things Toby is talking about today. But when the Campaign for Quality Care was pulled together, as Toby said, it was a campaign of all of the stakeholders who had an interest in promoting quality in long-term care in nursing homes. And that included not only the consumer advocates, but it included ombudsman programs, nursing home associations, social workers, the pharmacists, the medical directors. It included, all of the stakeholders, and there were more than 20 organizations that were meeting regularly to study the IOM report's recommendations and to develop detailed positions outlining how nursing home laws and regulations should be changed and strengthened. Ultimately, they reviewed a number of the different areas and put forward 12 issue areas of consensus where they provided recommendations for how they thought policy should be shaped around those different areas. And a couple of the recommendations included some supplemental areas where there was either suggestions for more detail or where maybe there wasn't complete consensus on the additional positions. But there were at least 12 or 13 different areas where they did have very broad consensus from the representatives who were part of this campaign for quality care. And those areas that they talked about included things related to residents' rights, related to access to the ombudsman program for residents and how the ombudsman program could be engaged with residents. Another area was related to access to care and Medicaid discrimination, the importance of a resident assessment and how that was such a critical aspect for quality care. It talked about the elimination of levels of care in nursing homes so that there would be a single set of rules that was recommended. And that's what we see today, a single set of rules that is not focused on level of care. Nurse aid training was a really important area of consensus where that had actually some supplemental positions that were included, but the fact that they came together and put forward recommendations as a group around nurse aid training was really important. Nurse staffing was another one, including focusing in on how to staff to ensure that there were enough staff there to meet the needs of all of the residents. Social services, mental health, survey and certification were some other areas where they put forward positions related to consensus that were positions with consensus. Enforcement of standards, Medicaid payment, excuse me, and coordination between federal and state governments. That resulted in a report that Barbara is holding there today, and they held some press conferences and briefings with staff on how they were sharing the information that they had pulled together. And it was something that all of the stakeholders, this multi-stakeholder group, had put forward and had come to agreement on how nursing home policy should look moving forward. And that was a really powerful objective for ensuring that there was a lot of support then ultimately for the passage of what became the nursing home reform law. The Campaign for Quality Care met for a number of years even after the law was passed. And for a long time, it focused in on a number of different areas and tried to, really focus on encouraging communication among all of the stakeholders and finding ways that the different groups and stakeholders could work together. So Toby, I'll turn back over to you in case there's anything more you want to add related to that.
I do want to add something about it because I was an active participant and I went to all of those meetings for that year. And I think what's very interesting is if you meet regularly with the same people week after week, you sort of stop talking and you start listening, and you learn a lot when you start listening. And we realized that there was a lot of agreement on the issues about where to go forward. So for example, I just want to give two examples. One was nurse aid training. Barbara used to run these meetings, Barbara Frank, whose picture we have here, and just amazing doing. She said, well, okay, the Institute of Medicine said all nurse aides should be trained before they go to work. Do we all agree with that? And Julie Trocchio, who is American Healthcare Association, said, well, no, I don't exactly agree with that. Now, nurse aid training was a big deal because at that time, half the states had no requirement for nurse aid training. So we knew this was critically important from what the residents said, from our experience. But Julie came to the meeting totally prepared. And she said, if we do what IOM said, that one model, that's one model, it's a good model, but there are other models as well. And she gave maybe half a dozen examples of states that got aides trained in different ways, before they were working, while they were working, different models. And she persuaded people that that made sense, that our basic point was that aides should be trained and competent before they provided care to residents, but there were different ways of getting there. So she persuaded us, and that's what the law says. It does allow aides to be working while they're in training. The second example I just would bring up is responsible parties in admissions contracts. The day we talked about that, American Healthcare Association's in-house lawyer came to the meeting where we were going to discuss this topic. And I asked her why nursing homes wanted responsible parties. And she said, we want to make sure that people, family members, neighbors who have legal authority to handle the money, either with power of attorney or guardianship, actually use the money to pay for care. Said, I agree with that as a resident advocate, because we've heard of examples where people get the money and then they use it for themselves. And we don't think that's right either. We want to make sure that people's money is used for care. And I said, is there anything else you want? She said, no, that is the only reason we need responsible parties. Well, when you read the nursing home reform law, that's what it says, that people can be asked to sign a contract, but only in a representative capacity if they have legal authority to use the residents' money. So, I mean, it was an interesting experience listening to people, talking to people, working through the issues, and coming up with an enormous amount of agreement. I would say, Lori, most of the issues that we discussed and came to consensus on were the standards of care for facilities, what we now call requirements for participation. The survey and enforcement was the least controversial issue for anybody because everybody believed that we needed multidisciplinary teams. Surveys needed to be unannounced, complaint and annual surveys all unannounced, and surveyors needed to be trained and competent before they did surveys. Completely non-controversial, and we didn't really get to enforcement very much. That was probably the area where we had the least agreement. So next slide, please. The work continued in other committees as well. The Senate Special Committee on Aging, which still exists, did its own 2-year investigation. And in May '86, right after the IOM committee report, came out with its own report, Nursing Home Care, the Unfinished Agenda. And it talked about 5 problems: poor nutrition, facilities not meeting standards of care, not enough beds, and so poor quality facilities could continue in operation. Next slide, please. Not required that HHA is not doing a good job of enforcement, making sure that facilities provide high quality care, and saying that the federal penalties were pretty ineffective. There were very few enforcement sanctions available. Basically, facilities were in or out of the Medicare and Medicaid programs, not really intermediate sanctions at all. Next slide, please. And this report also had, which was 28. Yeah, so they made recommendations about strengthening enforcement and making sure that everybody enforced existing law that was there. Next slide, please. There were also appendices with case studies, and they got a lot of attention. Now, I think what's a little bit different about this report is that it was a little more harsh, a little more strident than the IOM. The IOM was very measured, very strong language, very significant recommendations, but it wasn't naming names that this facility did this and that facility did that. This Senate Aging Committee report was a pretty intense situation in naming people. Next slide, please. So what happened is that the IOM committee report came out and there were bills introduced, and there was a Medicare bill, a Medicaid bill in the House. In the Senate, it wound up as one bill because the Senate Finance Committee has jurisdiction over both Medicare and Medicaid. And there were hearings. There were hearings in these committees. And Nickner was invited to testify at one of them, and neither Elma nor Barbara could go. So I was the person who testified, and I sat between Paul Wilging, Executive Director of the American Healthcare Association, and the person from representing state survey agencies. And we were all saying that the law should be enacted. And one of the members of the committee kept saying, well, where is the disagreement? What do you disagree about? And Dr. Wilging said, we agree on most of this. You should be doing this. We're not going to tell you where we disagree. We agree on most. Here's what you should do. And finally, the member said, you know, if we've got the industry and the residents advocates and the state survey agencies all saying these are good bills, these are important principles, we should do it, maybe we should listen to them. It was a pretty amazing experience. Next slide, please. So as I said, there were these multiple hearings, but really as important as the hearings are, really a lot of work gets done outside of hearings. And many of us would be meeting with Hill staff either in person or on the phone and going over and over these issues and which parts we liked and which parts we didn't like and what we wanted to do, which provision of which bill. That's where a lot of things got done informally. Next slide. The next thing that happened is that Kirk Douglas became the honorary chair of the campaign for quality care. When the campaign made the recommendations that Barbara was showing you, when we were presenting those to the world, Kirk Douglas was there as our honorary chair. Next slide, please. So there he was. This was the day it was presented. On the left is Senator John Hines from Pennsylvania. Kirk Douglas is in the middle. And to the right is Congressman Claude Pepper from Florida, the chair of the Senate this House Select Committee on Aging. And various members of Congress came. I remember Mr. Waxman came and said, we're going to make this report the law. We're going to do this. It's going to happen. And then they did. Next slide, please. So we got the nursing home reform law. It got enacted in December 1987. Next slide, please. And it changed everything about nursing homes. It made uniform requirements for Medicare and Medicaid, and it changed everything. The requirements of participation, survey, and enforcement. Next slide, please. So there were new requirements for facilities, quality of life. We've never had a healthcare law talk about residents' quality of life, but there's a recognition that this is a resident's home. A nursing home for many people is home for a long time. We need to recognize not just quality of care, but quality of life. Residents' rights were addressed, transfer and discharge, visitation, Medicaid discrimination, all kinds of provisions in the residents' rights. We got nurse aid training. We got a requirement for comprehensive resident assessment on a uniform assessment instrument. The federal law said that all states could do their own if they wanted to, but every state, in fact, has used the federal system because it was tested and validated and changed, and it was an excellent comprehensive assessment that not only looked at what medical conditions somebody had, what limitations, but what strengths people had. Who are they? How do they like to live their lives? What's important to them? This resident assessment was translated into languages and used around the law around the world because it was so excellent. All states use that instrument. And then the law requires that care plans be based on the assessment. And of course, much more in the standards of care. Next slide, please. So the survey, as I said, multidisciplinary teams trained and tested before conducting surveys, and all surveys unannounced. Next slide, please. And then enforcement. Next slide is the enforcement slide. So that called for a comprehensive list of intermediate sanctions that could be used and a process for the state to determine, and the secretary, which penalties to impose. So you would have more significant penalties if deficiencies were repeated, or if they weren't corrected, or if they were very serious. You look at the scope and severity of the non-compliance, try to have a small consequence for something not too significant, but trying to act before it became a really enormous problem. Next slide, please. So obviously, we had a lot of positive things going on in the 1980s, and I don't want to act like we didn't have positive things going on. Next slide, please. First, we had the HCFA staff who were sending leaking drafts of really bad things that were going on that we think it came from HCFA. I mean, where else would they have come from? But we think that that's how we knew residents' rights were eliminated entirely from requirements of participation, because we got a draft in the mail. Next slide, please. We had an amazing reporter at the New York Times, Robert Pear. He was just unbelievably knowledgeable about nursing home issues, also a whole range of domestic policy. And he was very interested in these issues and wrote regularly about them, often on the front page. So you could see back in the earlier slides when I said what was going on, a lot of it came from the New York Times. That's where he documented what was going on, who was opposing it, the Democrats and Republicans together. He was documenting constantly in the Times. Next slide, please. We had Kirk Douglas, and I can't tell you how important that was to have members of Congress interested, because Kirk Douglas was there talking about nursing homes and saying things had to be changed. Next slide, please. The nursing home industry participated fully in the campaign for quality care. And as I said, Julie Trocchio was really wonderful, very active and very informed, and brought a lot to us that people really respected. And American Healthcare Association testified in Congress in favor of the bills. This was important. Next slide, please. And Congress was different. It clearly was less partisan, and members were quite respectful to each other. So the Senate Aging Committee in 1982, the Republicans who were there were quite moderate. I mean, John Hines, we had a lot of people who really, I'm sorry, my computer is giving me problems. Very moderate and concerned people. This was the committee. Mr. Hines, Mr. Percy, William Cohen from Maine, David Dornberger from Minnesota, Senator Grassley, who's still here, was more moderate at that point. We had a different Congress. Next slide, please. So it's not that the Congress was controlled by Democrats, which had been my original memory of this. Until 87, the Republicans controlled the Senate and the Democrats controlled the House. But the senators, the Republican senators, were just as strong as the Democrats in being concerned about the deregulation from Subpart S. So it wasn't until 87, 88 that Democrats were controlling both houses of Congress, but it was a different Congress. Next slide, please. So in retrospect, I would say, we could say, well, the stars were aligned in 1986, 1987, but we didn't know it then, obviously. And we thought that the challenges were enormous, and we didn't really know how we would get the change. We thought that the administration was very hostile to us and listening to the nursing home industry in opposition to change. Next slide, please. So we have challenges today, and obviously they are enormous challenges. Next slide, please. But I think what we need to remember always is that the challenges were very significant in the 1980s as well. Certainly at the beginning of the decade, when we lost residents' rights entirely, it was very significant, but we persisted and we prevailed, and we need to continue. So I want to call on Ann and Lori now to give us their perspectives on what we can learn from the history of the reform law as we face the challenges that we have now. What do you think we learned? What can we do now? So Ann, want to start with you because you haven't spoken yet. Thank you.
Well, quite a tour de force. Thank you so much, Toby and Lori, and it's been an honor to work alongside you and with you all these years. I was not around for over 87 on Capitol Hill, but I was around when the stars aligned again in 2007 is when I joined the Senate Special Committee on Aging. And as you heard, that committee has played quite a role in advocating. It really has played an advocacy role in improving the nursing home sector and, in fact, all kinds of programs for older adults. And so in my tenure at the Senate Special Committee on Aging, I was lucky enough to be there when Barack Obama was elected president. The healthcare reform effort was the biggest one for that administration. And Herb Kohl was the chairman, and I worked for him. And he was a very serious legislator, even though the Senate Special Committee on Aging is an oversight committee. And he really didn't want to just complain about problems, acknowledge that there were, unfinished agendas out there. He wanted to do something about it, and he made that very clear. So really in partnership, and it was a more bipartisan time at that point as well, we worked with Senator Grassley, who was then on the Finance Committee, still is, I think. And we put together a package of reforms after we held a hearing, kind of a baseline hearing at the 20th anniversary of OBRA 87 in May 2007. We held that hearing, very balanced. Nickner was there, ombudsman, industry folks. And we said, okay, what have we accomplished and what still is missing? And subsequently, we sat down and we tried to figure that out. Toby Edelman was a big part of that. Nickner, now Consumer Voice, was a big part of trying to figure out what policy would make a difference. And we came up with a really good bill, I think, and it actually got incorporated into the Affordable Care Act because we insisted on it, along with other long-term care policy. And a couple of those provisions, which all build on the framework of OBRA 87. So I would say that that framework is the strongest one possible because all the standards are identical across Medicare and Medicaid, which is a rare thing. Normally states, have standards for Medicaid that vary considerably from state to state. And one of the marks of genius, I think, of OBRA 87 and the follow-up policy that we were able to add to it is that the standards are identical. So one of those standards was to have nursing homes report based on payroll what their actual staffing levels are, because they used to report kind of, a once a year snapshot, and sometimes it was very misleading. So the data were bad. So we got that fixed. Now we have the payroll-based journal. And we also got ownership data reported that we didn't have before. That took a long time to actually get implemented. Wasn't implemented as a final reg, although the Affordable Care Act was enacted in 2010 until November 2023. And that was, again, due to a big advocacy effort. That was the Biden administration. And we went to the White House and we said, COVID-19 was an absolute catastrophe. And part of the reason is that we don't have a clear enough view of who the owners are and who's responsible, who's accountable. So they finally promulgated that reg. So now I would like to say that I think we have an even stronger framework to really go forth and see not only who is doing a poor job, but who's doing a great job. If we combine the staffing data, the survey and cert data that Toby talked a lot about, the ownership data, and we do a better job of implementing the financial transparency provision, another one in the Affordable Care Act that really hasn't been implemented much at all, we will see really across the country at a national level who's doing well and who's doing poorly. And we can adjust reimbursement. We can call out organizations that are doing an awful job. We cannot wait around, for the Department of Justice to get to these issues years later. So I think that kind of proactive monitoring would make a big difference, and I hope that we can do it. Obviously, the National Committee, where I now work today, hopes that we will hang on to those staffing quantitative national standards, very important, long overdue. And Consumer Voice is really running a campaign to try to make that stick, to try to make them stick. That would make a huge difference. And we know that from analyses, including one done by the University of Pennsylvania, which estimated that if we keep those standards and promulgate them and enforce them, we will effectively save 13,000 lives a year. And that's unbelievably important. So we can't, let the clock, kind of spin backward. So the other thing I guess I would say is that looking ahead, we have such a much larger number of people who are living long lives. That's a good thing. But it also means that long-term care services need to be looked at ever more carefully and embedded at the community level so that we have skilled care, moderate care, light touch care, all available really, and housing to support those service delivery systems. So that is something that I do think we can build, and there are examples of that out in the world, like in Detroit, Michigan. Not necessarily where you'd expect to see that kind of work, but it's amazing and innovative. So I think we can look to all of the improvements that we've made to date, strengthen them, use them for proactive monitoring, quality improvement, and then essentially expand out that kind of monitoring and quality improvement to other providers that also offer long-term services and supports. So that is my hope, my dream, and I'll hand it over to Lori for her thoughts.
Sure, thanks. And, I completely agree with everything that you just said in terms of how we need to be, looking and moving forward. I mean, we've talked with residents and staff and ombudsmen who have been working in this field and know what conditions were like before the reform law was passed, after the reform law was passed, and how it made a difference. I'll never forget, hearing from one of our longtime residents who's been affiliated with our organization, Judith Mangum, who's lived in a nursing home for most of her life, for the majority of her adult life, who does remember and talks eloquently about what it was like before passage of the reform law and after passage of the reform law, when her rights were being respected, when people weren't being tied up and restrained, when she was actually being asked about her schedule and what was important to her, and had more of a say in how care was provided for her. And so, we need to continue making forward progress in terms of how we are looking to implement what I see as the great promise of the reform law, so that all residents are achieving the high quality of care and quality of life that was envisioned when the reform law was passed. And, I think we still have a ways to go for many residents, but that is something that we need to continue working towards. And these should not be partisan issues, and we should not be, focusing on whether these are Democratic or Republican or independent, legislators. These issues should be important to all. They're all of our family members. They're all of our parents and grandparents and loved ones that need care. And frankly, they're all of us who are going to need care at some point. And we are all going to want our rights respected. We're all going to want to have quality care with staff who are well trained and have enough people there that are going to be responsive to meeting our needs. And we're all going to want to be involved and directing our care and our lives to the greatest extent possible, no matter where we live. I also completely agree with you, Anne, that, we need to be looking at the provisions, what the people who are receiving long-term care and services said, historically, as part of the reports that have been done, as we listen to them today in terms of what they want, and look at how we can ensure that across the spectrum of care, not just in nursing homes, but expanding these basic tenets out to other people, as so many residents tell us when we first start talking to them about, what's life like for you living in a long-term care facility. Most residents say, I want people to treat me the way they would want to be treated. And I think that's true, kind of across the board. And that's how we need to be thinking about what are the most important things as we look forward to moving forward to implement the law. As Toby said, things can look grim right now as we're, fighting to maintain these staffing rules. But, we do definitely need to be focusing in on the fact that the requirement for staffing isn't that there be, just some bottom number. I mean, certainly, there's a number below which you should not be able to go in order to ensure that there are people available to provide care for individuals. But the real standard is meeting the needs of the residents in the facility. That's what the real staffing standard is. So while, we have a lot of conversations back and forth about having this minimum number in place, we need it because we know that without a minimum, facilities are not going to, on their own, many of them are not going to, on their own, put enough staff in place. And we've seen that to be true, which is why there needs to be a minimum staffing level. But the bottom line is we need to be ensuring that there's enough staff to provide care for individuals in the facility. And we need to be sharing our stories with our policymakers in order to ensure that we're able to continue moving forward and not go backwards.
Thank you, Anne and Lori. If we could just go to the next slide. I had a couple of things I wanted to say as we get into this time now. One is that the kinds of deregulatory proposals that will be forwarded or that will be introduced are probably not going to be surprising to us. They'll be the same ideas that were rejected years ago. There's not that much new under the sun. So we're still going to see about having less than annual surveys. Let's give facilities deemed status. Let them tell us if they're doing a good job all on their own. These are the kinds of things that we have fought before and defeated, and we'll see them again. And the second point I just wanted to make is that I think there's more information out now about the nursing home industry and how it does not use public money appropriately. Too much of it is hidden. Just a couple of weeks ago in the New York Times, the two researchers from the University of Pennsylvania who did the analysis saying that the nursing home staffing rule that's under such challenge right now, the numbers rule, would save 13,000 lives of residents a year. 13,000 a year, just an enormous number. And what they have at the end of their piece in the New York Times is, there is money there. The nursing homes are taking money and using related parties, and that's how they're hiding profits, and they're diverting money from care. So that's become public information. People know that that's true. And I think that helps us also going forward. So Matt, Ann and Lori, thank you. This is amazing. But maybe Matt, we have time for a couple of questions or comments from people. If you could do that.
We do indeed. And of course, there are questions and comments.
Okay.
And first, let me apologize for coughing into a live mic. It feels like this winter is the winter of endless coughs.
That's fine.
You mentioned some of the fights that you fought before that you're going to fight again on that topic. Several people in the chat were wondering, what about these proposed Medicaid cuts? What effect will that have on SNFs?
Yeah, well, if the nursing homes are worried about the staffing rule doing them under, they better be concerned about the Medicaid cuts because, the majority of the residents are getting Medicaid. And Medicaid cuts will be, no matter what they're called, be devastating for nursing home residents, devastating for states that rely on public money. The federal match is highest for the poorest states, like 77%. What happens if that money gets smaller and smaller? How are they going to provide care to people? How are residents going to get care? I think it would be absolutely devastating. And we're working on a piece now about that, about what Medicaid means for nursing homes. Nursing home
means a lot for
residents.
anybody who needs long-term care and services. I think Medicaid cuts will certainly have the effect of reducing quality care in long-term care facilities. I think it will end up resulting in more difficult access to receiving care and services, both in nursing homes and in community-based settings. It would really be devastating for people who rely on caregiving services and being able to access and afford them.
Yeah, we're going to fight this hard, and we need all of you to join. I was noticing that the Senate Aging Committee actually held a hearing last week, and it was on longevity, which is a great thing. But it does mean that we need much more attention paid to long-term care streams of funding and basic access, as Lori was just saying. I mean, there are millions of dually eligible low-income Medicare beneficiaries who count on Medicaid to pay their deductibles, co-pays, premiums, and so on. If that money disappears, they will effectively not have access to Medicare. And I'm not sure that that's as well understood by the public as it should be. So the more that we can amplify this kind of information, the more that we can work alongside and with providers who well understand, many of them, how dire, it would be to slash the largest healthcare coverage program in the country. It would blow up the healthcare system. So we have a fight ahead of us. I feel somewhat confident that there's going to be enough of an outrage and an outcry that we can stop it, but it's going to be tough.
Oh, well, thank you all.
That's reassuring.
And somebody asked, you mentioned a program in Detroit. Could you go over that again?
Yes, it is a wonderful program. It's called the Tomei Rivertown Initiative, and it's purpose-built housing for low-income older adults that was put together by Presbyterian Villages of Michigan. And then because older adults need supportive services, they went out and recruited the best providers, long-term care providers, to serve that population that's living there. And so that was a greenhouse, which is a transformed nursing home. a PACE program, and then the Detroit Area Agency on Aging, providing home and community-based services through Medicaid. So it's a multi-payer system that is working amazingly well, and we're studying it for all of its richness and everything that we can learn from it so that we can bring that forward and try to get the Center for Medicare and Medicaid Innovation to pay some attention and want to do a demonstration on how you embed long-term services and supports as a normal community service, normal part of community life. So would love to talk more about it, but it's a big subject. So maybe another webinar, or give me a call, or send me an email.
All right. That sort of relates, I think, to a question from a Charles Sabatino. I don't know if anybody's ever heard of him.
Yeah.
Why do you think the built environment gets so little attention as a reform element? Even with the most dedicated staff, large institutional environments impede quality, dignified care.
There are a couple of reasons for that. I mean, first of all, the built environment is something that it isn't just an HHS issue, it's a HUD issue. And frankly, we need some help to get HUD to pay more attention to the built environment and to incentivize, transform nursing homes instead of, fixing up the institutional hospital-like facilities that we've had around for many, many decades, which were, of course, incentivized initially by another law that built a lot of nursing homes to look somewhat like hospitals. But those days, we hope, are passing. We really need to rethink the built environment, but it does involve more focus on housing. So we need your help to go talk to HUD as well as HHS.
Yeah, I think that's right. And I mean, I think, certainly people would like smaller settings. I think they would like settings that are more responsive to their needs, kind of as you're talking about, Charlie, that I think that the current model we have is just so entrenched right now. It's like moving a mountain, right? And so it's how do we continue to push and chip away at that mountain and get it moved so that we can focus on other alternatives.
Bill Burton paid for these large facilities, and that was how we funded them. So now we need a different model. No question about it.
Thank you all for that. I know we're slightly over our 3 o'clock target time, but we've had one very patient hand up. Nancy, I don't know if you still have your question, but you need to click on your mic to unmute yourself if you want to ask that aloud.
Thank you. Hi, Toby.
Hi, Nancy.
Hi, Lori.
Hi, Nancy.
Hi, Charlie. It is important for people to understand that what Toby has explained is that we are repetitive. We are repetitive over the last 50 years in the way in which we go about trying to influence the influencers and the changing of who's in charge. But Toby, Lori's organization, and others have been real models as to the perseverance of advocates to hold people accountable. And I hope that the information around ownership is looking better and that people are using it. In California, we recently had a provider who owns 2/3 of the homes in the rural areas get pinged. He also had the highest rate of deaths during COVID, but he's still in operation. And he's in operation because one part of his business is X and another part is Y, and he tries to meld them together. And he does successfully because people don't look at it and the state doesn't look at it and the feds don't look at it. So that's my comment. I apologize for going on.
And it's great to hear your voice, Nancy.
Thank
Back at you or another person. Okay.
Thank you. We'd love people who are interested in ownership. So important. And
absolutely.
Yeah.
Thank you.
All right. Thank you, Nancy. On that note, we are just a little bit over time. Really nice job to cover that much information in that amount of time. So thank you all very much. And thank you particularly to Anne and Lori for joining us today and
Absolutely.
for fabulous comments and discussion. Just an excellent presentation, which has also been noted in the chat and the questions panel. As noted earlier, for all of our attendees, you will be receiving a follow-up email with links to the slides, ideally to the recording if it processes, and a brief survey to let us know how we did today. So please do fill that out for us. Thank you all once again, and I'll conclude today's presentation.
Thanks so much.
Thank you.
Take care.
Bye-bye.